Hi guys, we are going live here in a little bit. I am waiting for Dr. Megan Pallister to join us. There she is. Let me add her. Hold on. Where's Megan? Right on time. Hi there.
Hi, how are you?
I'm doing well. How are you doing?
I'm good.
You're a new mom.
Yeah.
Like really new. When did you deliver?
He is going to be 7 weeks old on Tuesday.
Yeah, well, congratulations.
Thank
Do you go
you.
back to work soon?
I go back to work a week from Monday.
Monday. Okay. A
Hmm.
little bit longer. Well, I
Yeah.
appreciate you taking time on your mommy time to have this discussion with me. It's a discussion or a topic that I get asked about a lot. And again, I'm Shannon Clark with Babies After 35, and I'm being joined with by Dr. Megan Pallister. And you want to tell the audience where you work, where you're located?
Yeah, I'm in Houston, Texas. I work for Kelsey-Sebold. I deliver babies at the Women's Hospital of Texas. My clinic is in Tanglewood,
Mhm.
Memorial area, and also at the Women's Hospital of Texas Clinic. We have a clinic there. But yeah,
Yeah,
that's
and
where I
you're
work.
on Instagram at Dr. Megan Pallister, OBGYN, I think is
Yeah.
your handle. Yeah. Okay. Well, we have several people on, so we'll get right with it. The way it works is we're going to go for about 30 minutes or so, and then I'll scroll through to see if there's any questions. We're going to talk about endometriosis, just the basics. And then we're going to talk a little bit about the fertility part. I want to keep it around 45 to 50 minutes tops because ultimately Instagram will shut me off. So, and I want to save video. So here we go. All right. First of all, tell us what exactly is endometriosis.
So endometriosis is the lining of the uterus that's outside the uterus. So it can be on the lining of the abdomen called the peritoneum. It can be on the ovaries. It can be on the intestines and the bladder. But it's these little implants, the actual lining of the uterus where it really shouldn't be.
Okay. And so how do we think that this happens? Why would the lining of the uterus be located outside of the uterus?
There's a lot of theories, and we don't really know. The most realistic theory to me that makes sense is kind of a retrograde flow. So during menses, the lining of the uterus sheds like normal, but it goes backwards through the fallopian tubes and then can implant inside the abdomen. But there are definitely genetic factors because we
Right.
know that, if a mom or sister has it, then I'm the patient's having these symptoms, then I'm more likely to think this is endometriosis, and there can be immune factors too.
So yeah, so just so the audience knows, during a normal menstrual cycle, the lining of the uterus is shed and the uterus is connected to the fallopian tube. So there is probably a certain amount of menstrual blood that does go back the wrong way instead of out through the cervix and the vagina that can go through the fallopian tubes. It's just that some women have that ends up causing a problem and could cause endometrial implants. Is that kind of what we're thinking with the retrograde flow theory?
That's what I mean. That makes the most sense to me.
Yeah, and then there is a genetic component, and as Dr. Pallister said, if she has a female come in with certain complaints, asking about family history of endometriosis is also very important. And then one other way I have heard of it, is with when there's certain kinds of surgeries that are done on the uterus, like a C-section or something, because we are opening the lining of the uterus to get the baby out. We could, not even knowing it, draw some of those cells outside the uterine cavity that are allowed to implant on other organs. So that is one thing that we believe happens as well, correct?
Yeah, I've definitely seen that in a few
Yeah,
cases. Hmm.
yeah. Okay, so how common is it generally?
It's endometriosis.
Yeah.
It's really common it's diagnosed mainly in 20s, 30s, and
Mhm.
early 40s, and they believe like probably 10%, I think, people. Well, I think it's like 10 to 40% of people. What
Yeah,
what would you
it's
say?
a wide range as far as I think they say about 1 in 10 women will have it.
Yeah,
It doesn't mean that one person's going to have it really bad. There might be some of those 10 women that have it and don't really have any symptoms, so they don't know. So it's probably more common than we think, but it
agreed.
typically produces, or from what again, I don't do gynecology as much anymore, but I know young females can have it when they have unexplained pelvic pain. But then also women can get it or get diagnosed with it actually as late as 30s and 40s when they're trying to get pregnant
Mhm.
and they realize that's what they have and they didn't really know that's what was going on. So I have heard that as well, but it is, also more common in African American women, and they too tend to present at a younger age. Do you find that in your practice as well?
Yeah, I do. I mean, I feel like a lot of women just kind of live with it for so long that they end up coming like much later than they initially started with the symptoms, which is unfortunate. So I see it mainly in, in the infertility, like workup for infertility, things like that. I do. Yeah.
So when we talk about who gets it, actually anybody that has a uterus that has menstrual cycles can get it. Or also you could be born with it too, and have nothing to do with either. It's just that you're predisposed to it, and it happens as you're developing as a baby. But, what are some of the signs if someone comes to your office and they're complaining of certain things? What are those certain things they complain about that would make you think, maybe this is endometriosis?
So mainly it's going to be really bad pelvic pain, mostly before your period and during the period. So that's going to be really severe pelvic pain. Also, you can have pain with urination, pain with bowel movements that can indicate that you could have those implants, that lining of the uterus outside on the bowel, on the bladder. People are going to, they can also have other symptoms, nausea, things like, general symptoms, but usually it's really the severe pain during your menstrual cycle and right before and after.
Yeah. So, and for the audience as well, in the pelvis, you have the rectum, the bladder, and the uterus. And so if there's, and all women during their menstrual cycles will have some kind of discomfort, but, I think it's hard for women to know what's normal and what's not. And I guess the biggest piece of advice I would give to young women, especially, or even older women, if it's getting unbearable, or you're starting to have more pain with going to the bathroom or urinating or having a bowel movement during your menstrual period time, that might be a red flag. Do you ever see patients come to the office that are having those types of symptoms too? Like, during my period, it's really hard for me to have really painful for me to have a bowel movement, like you said, or
Definitely.
hard for me to, yeah. So that's, it's really hard for us to explain on a video, this is what it feels like, because every woman's different as far as what symptoms she has during her menstrual cycle. But that's why, and while we're at it, having routine care, gynecologic care especially, is so important, so that those questions can be asked of you. Would you agree?
Yeah. And one thing I forgot to mention is pain with sex. So that can be, that is probably one of the more common, that's a hard symptom to go at initially, honestly, but that is definitely something with those other symptoms. If you're telling me you have that is also a big indicator of endometriosis in a lot of cases.
Yeah, so it's important. I always recommend, and I don't know how you feel. You do more of the general OBGYN than I do, but what is your feeling on doing some of those period trackers? I know back in my day when I was training, women would hopefully just mark it on their calendar. They're in their pairs. My period started here and ended here. But we really never had anything that said my flow, I bled this many days, my flow was this heavy, I had pain, I didn't have pain. And so some of these period tracker apps that you can get actually kind of ask a lot of those questions. You could plug them in. Would you recommend that women do that if they're starting to have pains?
I love that. I love when they come to me. I'm a really big data person. They come to me, this is my period, this is how long it was. It's helpful in so many ways, not just for endometriosis evaluation. But yes, those apps are great. I always recommend Clue app. I have no affiliation with it, but I read a study a while ago that it evaluated a bunch of them, and that was the most accurate, especially for ovulation. But which is what we're talking about. But that app is those apps are so helpful to evaluate, okay, when is this pain? How bad is it? I definitely recommend them. Yeah.
Yeah. And I'm out of that. I haven't done gynecology in years, but, I hear, and from what I know about the Flow app, I know about Clue. I know those are probably two of the most popular ones. Yep. But anytime you can come in, and it's also good to just have that app that's actually asking you questions you probably never would have thought of. And that way, when you go to your doctor, you can say, well, this is how I was feeling during these days. And it would help them to kind of tease things out and, may or may not help point to a diagnosis.
Agree.
So you spoke about all the different areas where endometriosis can occur. I've seen it when doing a C-section, and the patient may or may not have had a diagnosis of it. It's basically the reason why it becomes so problematic is when you have that normal menstrual cycle where the lining of your uterus is being shed and you're bleeding vaginally, those little implants on all those different areas of your pelvis are bleeding too, and they get inflamed, and that's why it can be so problematic. So, as far as the most common areas, are there any certain areas within the pelvis other than the uterine lining where those endometrial implants might be?
So I think most commonly we find them in the ovaries, because we see these cysts. They're called chocolate cysts.
Yes.
And we often find these, like you said, sometimes you're doing surgery, you didn't even realize the patient had them, but sometimes you're doing surgery and you see these chocolate cysts, and those are indicators of endometriosis. And that may be the only place you see it, because a lot of times the implants are microscopic and you can't actually see it with your own eyes. But those are the most common areas, and they can be in both ovaries, they can be in one, but they definitely the most likely place I see it.
Yeah, and so you touched on endometriomas too. So I know some of the viewers or listeners or viewers, I see endometriomas a lot when a woman's pregnant and we're doing the ultrasounds and we see a cyst, and there's certain things on ultrasound that make it look like that could be an endometrioma. And so a lot of times, you might find a woman that has a cyst and go in to take it out, and it is actually an endometrioma. So if you see something like, does she now have a diagnosis of endometriosis?
So honestly, the only way to diagnose endometriosis is with your own eyes, with our eyes, looking with a laparoscopic surgery. So that means cutting into your belly, putting a camera in there and seeing it, and really we should biopsy it and we should send it to the lab. Okay. We don't always do that. That's not always recommended for many reasons that we probably will get into. But the endometrioma on ultrasound, which is, I would never recommend an ultrasound to diagnose endometriosis, but you can get an ultrasound for pain, and you can see if there's, you're looking for a cyst, and at the radiologist may say, this cyst has appearance like an endometrioma, or that chocolate cyst, that cyst that's made by endometriosis. You can never be 100% sure, but like you said, there are these, on ultrasound, you see it too, like well, the way that cyst looks, you're like, that looks like an endometriosis cyst.
Right. So even in, pregnancy, unless it's causing problems, we leave it alone, and we follow it over the course of the pregnancy to see, if it's something that gets bigger. Most of the time they don't, and it doesn't become problematic. So that is pretty common too for us to see something like that. Okay, so let's talk about, one of the things that makes us have periods is estrogen. Our estrogen levels get high, then we have the drop in estrogen, and then we bleed. So we're taking out the fertility. We're not trying to get pregnant. We're just a woman that has endometriosis, or we think, and we haven't gotten to the point where we actually put do the surgery to look with the scope to diagnose it for sure. Is there anything that we can do to help decrease those estrogen levels to kind of help with the pain that's associated with it?
Yeah, I mean, the most likely thing I'm going to say here is birth control pills, or that could be first line, but any type of birth control, the NuvaRing, I mean, the patch, even IUD is really great. So it doesn't have to have estrogen in it. But these things are going to help regulate those hormonal levels and can help tremendously with the pain. But then there are some lifestyle factors. There's a lot of research out there. Obviously, a lot of people are really have their heart into the research for endometriosis, and they found that decreasing caffeine, decreasing certain alcohol intake, definitely exercising, keeping a healthy lifestyle is definitely going to decrease that pain related to endometriosis.
But and the thing with exercising as well is women of a higher BMI or body mass index or higher weight do have, and it's from the adipose tissue or the fatty tissue, they do have higher levels of circulating estrogen. So if you're have a higher BMI, that more than likely means that you have a higher estrogen level, which could also impact how symptomatic or how much symptoms you have with your endometriosis if you have that. So also the exercise and maintaining a healthy body weight is also important to prevent the symptoms from occurring. So, we've talked about a lot of cool things, but, you talked about diagnosis. So we have what we consider, kind of screening kind of test that we do, which it would go with the interview and maybe an ultrasound to see if she has endometrioma, those types of things. But talk about specifically how it's diagnosed. How are we going to get a definitive diagnosis?
So I won't say the definitive diagnosis is always going to be in the books for everyone. So the way I approach endometriosis is we do a pelvic exam. We see if there's any masses, if there's a reason for an ultrasound. If there's tenderness in an area, then an ultrasound may be indicated. Oftentimes I'm going to first treat the symptoms. And so I'm going to offer, a trial of either NSAIDs. So that is an NSAID is a non-steroidal anti-inflammatory. So it's like Motrin, ibuprofen. often naproxen. And then if they've been trying those, usually people see me, they've tried something, right? And so they've usually tried that didn't work. So usually then we're going to talk about hormonal options. And usually if those work, that's an indicator that you may have had endometriosis.
Yeah. Okay.
And so that if we can get your treatment, if you can get your pain and your symptoms under control with those medications without ever actually doing a surgery and cutting into you, then great. That's what I want. I have not done a what we call diagnostic laparoscopy on anyone in a very long time, because we can usually get it under control with medications and, treating the symptoms, because there's not usually something you need to do in the surgery and something to remove. In my line of work. I mean, if you're talking about infertility, obviously that's different.
So and I think it would go along with how severe, ultimately, if it can't get controlled with the measures that you're doing, then the next step might be doing the scope to know for sure that's what we're dealing with. And to rule it out. And, the laparoscopic surgery, for those that are listening, may not know, that's where I haven't done one since residency. I remember I was a resident and I was like, I hate this. I'm never doing it again. But basically they make, I don't know, how many incisions? 2, maybe?
3.
Well,
2 is probably, all you need for diagnostic.
Yeah. So 2 little incisions, one usually by the belly button, one somewhere else. And they go and inflate your belly button, your abdomen with some, what is it?
CO2.
It's been a long time. And then they take the scope in and they look, and they can actually visualize the lining of your intestines, your uterus, your ovaries, and all that, to see if they see any endometrial implants. And while they're there, obviously, if they see something, they'll biopsy it, as Dr. Pallister said, to get a definitive diagnosis if that's really what it is. So go ahead.
I was just going to say something I always tell patients, and why, some people come to me saying, I want surgery. Obviously, I want to be diagnosed. And the issue with doing surgery is oftentimes, again, not for infertility, if we're not at that level, if we're much younger and we're not dealing with wanting to get pregnant at this point, is that what it looks like in your belly on surgery, like when you do surgery and you put that camera in, doesn't often compare with your pain. So you could have the worst pain in the world, and I could do surgery and there's nothing I see. And so that doesn't solve anything. So that doesn't correlate as well. So I always tell patients, and then I can do surgery for, I'm taking a uterus out for fibroids, something completely different. And I go in there and she has horrible endometriosis and she never even complained of pain. So it's weird. And so that's why the surgery, I don't push initially.
Yeah. And that makes sense. I mean, because there's not a strong correlation. Just because, like you said, if you have somebody with terrible symptoms and you go and you don't see that much, it doesn't mean, well, she really doesn't have terrible symptoms. Of course she has the symptoms. So it's not going to negate what the patient is feeling. But it could just say, yes, you do have endometriosis. Definitely. And if that's what you're looking for, that's great. But again, I don't want anyone thinking that if you go in and you don't see it that bad, that means that we don't feel that you have the symptoms. We know you have the symptoms. So we talked a little bit about the treatment as far as medical treatment, and you said I guess it kind of all boils down to whether or not a woman is wanting to have a family or not. At what point, as a general OBGYN, if you've tried the conservative measures, you may or may not have done the laparoscopy, but she's getting to where she wants to get pregnant. And that you have a high suspicion or a diagnosis of endometriosis for sure. How do you counsel her about what the impact endometriosis might have?
So we do know
on her fertility.
We do know that it's hard. If you think you have endometriosis and you haven't tried to get pregnant, then I would say that it's likely that you're going to get pregnant naturally. But if you have had a history of having trouble getting pregnant, then it's possible that endometriosis isn't. If you have those symptoms and you're having trouble getting pregnant, it's very likely you have even higher likelihood you have endometriosis, and that's causing your infertility. Did I make sense there?
Yeah.
I don't know if
I mean, it's difficult because I think, and just from being on social media, I am a maternal fetal medicine specialist. I don't deal with endometriosis, but I get asked a lot because I am an OBGYN, and I think the common thing that I hear a lot is that they're told they have endometriosis and that you're going to have a hard time getting pregnant.
Yeah.
And they're told this at such a young age. You may or may not agree with me. Unless the woman does not have a uterus, no one should be told they have no chance of ever getting pregnant.
Oh yeah, I totally agree.
Because I hear that all the time. I was told I could never get pregnant, and I'm pregnant. And, I think that unless there's something there that does not allow a baby to be in your body, I disagree with people ever saying that. So having an endometriosis diagnosis, it does not mean you're never going to get pregnant.
No, and it doesn't mean you need an immediate referral to the infertility. That's why,
Right.
that's what I said. I say you need to just live your life, try to
Mm-hmm.
get pregnant. And we're going to use, we're going to have that on the back of our minds that this may be, if you're having trouble getting pregnant, come see me in so many months, depending on your age. And if we're having trouble, we're going to evaluate for that, a little bit more intensely, I think, or, have that in the back of our mind more than I would in someone else.
Yeah. So, and we'll talk a little bit. And again, I want to stress again, I don't want women, especially if you're a 25-year-old female and you have endometriosis, to think that it's over for you.
Exactly.
I think that's could be very damaging mentally and emotionally. It doesn't mean you're not going to have problems, and you may have an issue, but it's not fair to put that in someone's mind that early, I think. And I hear that all the time.
Oh, yeah.
I hear that all the time. So let's talk a little bit about, what is it specifically about endometriosis that does cause problems getting pregnant? What is it? Why does endometriosis in someone cause either problems conceiving or infertility?
So the theory behind it is, like you said before, those implants, just when you menstruate, that uterus swells and you get cramping in the uterus, and then those little areas are going to swell and get inflamed. And that can cause scar tissue, or what we call adhesions. And so that scar tissue tends to be around the uterus, the ovaries, the fallopian tubes. Mm-hmm. And if it does involve the fallopian tubes, which often it can scar them. And those are very delicate structures. And if you scar that fallopian tube closed, then you don't have a way for the egg to leave the ovary and go through the fallopian tube and meet the sperm to make an embryo. And that's the most common way it's going to cause infertility. And we can evaluate for that, though. So there is something called a hysterosalpingogram, which is something that I would do if I'm evaluating for infertility, not just someone who has endometriosis and coming to me, can I have babies? Again, I would say you're most likely going to have a baby without any issues. But if it comes to the time where you've had trouble for a certain amount of time and you're really wanting to get pregnant, then that is a test we could do. And that evaluates if the tubes are open on either side. It doesn't say you don't have endometriosis, but it says that those tubes are not scarred closed, which is something that endometriosis can do.
Right. And then there's the thing with the whole, because it is an abnormal response physiologically and immunologically, if your immune system is kind of revved up because of these endometrial implants, they could not allow the sperm to do its function. They could not allow the egg to do its function just at baseline. So there's multiple things. And also the endometrium within the lining of your uterus could also be abnormal, because endometriosis is an abnormal process to begin with. So there's multiple things, but the most common one that you hear about is you had scarred or blocked tubes from the endometriosis that causes it. And of course, along the way, I've heard several women that had endometriomas on their ovaries that, and we'll talk about this. So a lot of women who've had their entire ovary removed because of an endometrioma. I think from when I was doing that, we tried to preserve the ovary as much as possible. Sometimes it's not possible because it does take over the ovary. So is that still what we try to do? We try to preserve as much ovarian tissue as we can when people have either cyst or endometriomas on their ovaries, correct?
Yeah, exactly. I mean, and that's why I like to do conservative therapy first. I mean, that endometrioma, depending on the size of it, you're not going to go in and remove it because it can shrink, or it could just not grow at all. And it can be really small. There's a size limit at what we should probably operate on that and remove it. And if we do go in to operate, then yes, you're going to try to core that out. You're going to leave as much ovarian tissue as you can, especially if they're on both sides. You really don't want to remove an ovary, and definitely not both. And so anytime I go into surgery, I make sure that the patient knows that I'm going to try to leave both ovaries as intact as they should be. Okay.
One of the questions I forgot to ask, but I wanted to talk about, the pain with endometriosis is real. And I know that there's different therapies that can be, we're talking about specifically for pain control. What is recommended now as far as pain control? And the reason why I ask that is, there's a lot of restrictions, even on my end, as far as certain medications that we can or cannot prescribe. And we really are limited in some degrees as to what we can prescribe. But what medications have you found that help with the pain control in patients with that are having pain from endometriosis?
So yeah, so oftentimes, I mean, we'll start with the anti-inflammatory medications. Often naproxen, even something called Toradol can work in a pill form. And then ibuprofen, the over-the-counter stuff as well. But usually, like I said, most people have tried that pretty religiously before they come to see me. And so then you're going to try the hormonal options. And when I went to a conference about 2 years ago, the most recent updated because it used to first line treatment, meaning the best treatment, the gold standard for endometriosis used to be birth control pills. And now we're saying the Mirena IUD is actually a better treatment for endometriosis. And that's a big step for some young girls. They've never had an IUD and then they want to put the Mirena, but there are other smaller IUDs as well that are probably just as good. But that is supposed to be really helpful in, and I've seen it be really helpful in the pain from endometriosis. But birth control pills, the NuvaRing, the patch, any of these hormonal options are a good way to manage the pain.
Okay. So pain does not always mean you have to have some kind of pain pill treatment is what I'm trying to say. There are other things that we could do, especially, based on, it's an inflammatory reaction that can cause a lot of the cramping and that. So that's why non-steroidal, as NSAIDs, non-steroidal anti-inflammatories help, like ibuprofen and Toradol and things like that. So that should definitely always be tried first in patients, correct?
Yes, I agree.
Yeah. So there was another good question I was going to ask you. Oh, where did it go? Surgery. Okay. So, one of the things I talk about a lot of different topics related to pregnancy and fertility and the role of the ObGyn versus the fertility specialist. You are a general ObGyn, and I'm sure you refer patients to fertility doctors all the time for this type of problem. At what point do you recommend, or what factors are in play when you would say, it's time to go see a fertility specialist if they're not able to get pregnant?
So I think it depends on, infertility specialist that I refer to, it really depends on the age of the patient and how long they've been trying. So if you're younger than 35, then it really can take up to a year, and I can give you a full year to get pregnant. And that is a natural process, and try not to get stressed. And I usually have patients come in around 7 or 8 months because they're really stressed at that point. And we talk about the workup that we can start, because that usually does take a few months. Usually the sperm analysis takes the longest to get.
Well, I'm going to stop you there, because this is an important point. Yes, say she has a diagnosis of endometriosis based on whatever, or a scope laparoscope confirmed it. If you can't get pregnant, it doesn't mean it's 100% because of the endometriosis.
Exactly.
You still have to do your due diligence and do a fertility workup, right?
Yes, totally.
We can't always blame the woman, and it might be something else with her and not the endometriosis that's causing it. So I'll let you jump back in. As far as you said that you started going into the sperm analysis, the semen analysis.
So if you want to talk about we need to evaluate everything before you get sent to an infertility doctor. There are some things that I could help you with. Right. A simple thyroid disorder could be the cause of your infertility. We want to check a bunch of other blood tests. And then sperm analysis is something, because we know that up to 30% of infertile couples could be sperm related. So we definitely want to do that. And then we want to check the structure of your uterus and the structure of those tubes. And again, the tubes can be closed for other reasons, like scarred closed for other reasons. It doesn't have to be endometriosis. But that is, with your history and then them being scarred, that's an immediate, got to get to the infertility doctor, because then likely IVF is needed. Yeah.
So I think it's an important point to make. Yes, endometriosis can be problematic for fertility, but it doesn't mean that's the cause. We still have to do our due diligence, and it can start with your general ObGyn. And then I'm pretty sure every general ObGyn has a point where they are like, it's time. And you can discuss that with your general ObGyn too. Say, at what point would that be necessary? I think, if it's an ObGyn you are established with, having a rapport with them and doing their workup that they feel is appropriate. But once additional help is needed, then they would refer you on.
Yeah.
Okay, so we're going to stop real quick, and I'm going to go back and pull up some questions here. Hold on. Let me see. I went up too far. Okay. That makes sense. So yeah, well, this is kind of may or may not be related to the topic, but I hear a lot about I lost one of my fallopian tubes mostly due to ectopic pregnancy. So since I have you here, you know, a woman loses one fallopian tube, what is that impact going to be, if any, on her fertility?
So yeah, it's interesting because we think that the other fallopian tube can actually pick up the egg from the
On
other
the other
ovary.
side,
Yeah. And
Mm-hmm.
so we actually don't think it decreases fertility, which is really great because a lot of people have ectopic pregnancies, and it's definitely been in the news more, and people have stressed more about it, right? And we used to do what's called a salpingostomy, which is, well, I've actually never done one because it's not recommended anymore.
I used to do them.
Yeah.
My God. But I'm a lot older than you. Yeah.
You're not that old. You trained, but I was a med student when you were my or you were my fellow.
Well, I did residency in 2000, 2004 though. So we were still doing salpingostomies back then.
Yeah, sure. Yeah. And I think some people are still doing this. So some people watching this may have had one, and it depends on the person and situation.
So let's talk about it. So salpingostomy means if you find the ectopic pregnancy within the tube, and the tube's a long, kind of curly, not curly, but long structure, and it's kind of thin, tubular. Then we would used to cut a little hole over where we thought the ectopic was and take the ectopic out, and then let it heal on its own. So you're saying that's not anymore, is not preferred. Not recommended, because that's likely to scar the tube, and then you're likely to have another ectopic pregnancy in that same tube. And anytime you do surgery, you have to remember that, well, not you, but anytime patients have to know that anytime you enter the belly, that's going to cause scar tissue. So you don't want to have increased risk later on from something surgery you didn't need initially. So what is recommended now is to actually just remove that tube and remove the ectopic pregnancy with the tube in its entirety, and leave the ovary, of course, in its natural position. Don't bother the ovary at all. Yeah, and just while we're at it, for ectopics, so they're not always located within the tube. They could be at the end of the tube, attached to the ovary. They can be inside where the uterus meets the tube. So it all depends on where it's at. And I diagnose ectopics all the time doing ultrasounds, but I can give an idea of where I think the ectopic might be, but they really don't know until they actually get into your abdomen and find out. And this is for the ectopics that require a surgical intervention. Not all of them do. But the ones that do require surgery, they don't really know exactly where it is and exactly what they have to do to treat it until they get into your belly. So that's for the ones that require surgical management. So that's okay. Oh, we have somebody from Dublin. Does long-term use of NSAIDs have a negative effect on a person? I mean, I guess it can in other medical, it could cause kidney issues for sure if you use too much. It's not like a dependent medication, if that's what someone's asking. Right. Now, so there's not really a tolerance that's developed to NSAIDs. I think the main thing is you have to take it as prescribed and not take too much. And I think if you're on it for months at a time, you do have to worry about the liver and kidneys. So that's why you have to be under supervision. If you're taking chronic use of NSAIDs, you should be under supervision by a doctor. This is not something you should be doing on your own. Okay. And then the other thing is, it can cause GI issues. You can cause an ulcer. When I was a fellow, I have really terrible headaches. I've had them my entire life. And I was taking so much ibuprofen. I didn't realize it until I got a big old ulcer in my stomach. And then I was like, oh yeah, I've been taking a lot, because I was half sleeping and I would just pop in, so you have to be careful. Yes, it's over the counter. Ibuprofen's over the counter. A lot of NSAIDs are over the counter, but that doesn't mean you could just take it at will. You still need to be, especially if you're needing a lot of it, you need to talk to your doctor about that. Agreed. Okay. My RE suspects endometriosis. When I discussed my options with my OBGYN, she was very dismissive, trying too hard to get pregnant. What can I say to my OB to prompt her to help me? So you go to an infertility doctor, but your OB-GYN. Yeah, so I'm not sure, Serena girl, if you want to clarify, it sounds to me like you've already been to an infertility specialist, RE, I think that's what that means. Yeah. But if that's the case, I'm not sure what they're wanting your OBGYN to do, because usually the REI would do it. So we can definitely overlap in diagnostic and evaluation procedures, but I don't know what
symptoms that your
Yeah.
OB, like where they're differing, I guess,
Yeah.
is
I don't
hard
know.
to say.
I guess, and I'll just say that broadly, if you are ever feeling dismissed by any physician, no matter what you're doing, no matter what your issue is, and you don't feel like they're listening to you, you might need to find another one.
Second
And
opinion
find
is
somebody
totally
yes,
fine.
A second opinion is okay.
Everyone is entitled to a second opinion.
Yeah.
Third, if you want it.
I agree. Your cycle is, does that mean you don't have ovulation? I don't know. SD Tackley 24. If your cycle is beginning on every, I don't know, on every month, does that mean you don't have ovulatory issues?
So like if you're, if it's on time?
Yeah, I don't know what she's asking, but we'll see. So let's talk a little bit about ovulation. Does, traditionally if you're having regular periods within a day or two of every month, you're regular, your flow is normal, whatever, then there's a good chance you're ovulating, correct?
Yeah, and it's a good chance that your egg level is normal. I have a hard time saying that, but
well, so let's just say it just means if you're having normal cycles, and that doesn't mean
then you're most likely ovulating.
Yes,
yeah.
So most likely ovulating if you're having normal flow. That doesn't mean if you're having irregular that you don't ever ovulate. You just might have irregular ovulation. So yeah. I'll just add a little side story. I had a person come to me in the medical center where I work and said, I have a period about every 4 months, young female. And I said, okay. And she wants to get pregnant. And she said that her doc said that, well, that's okay. Whenever you want to get pregnant, we'll just give you Clomid, which is a medication that can, stimulate your ovaries. And you can add what you feel too. I wanted to say that, having normal menstrual cycles is important. If you're not, especially if you had them, then they stopped, or you've never actually had one, you need to be evaluated to find out what's going on. Yeah. Right?
Yeah. I mean, so many women and young girls come to me and say, oh, I just don't get periods. That's how it's been my whole life. I'm lucky, or, that's usually something related to ovulation dysfunction. And not just because maybe you don't ever want kids. Okay, fine. But it can definitely affect your health. It can cause risk for diabetes in the future, risk for uterine cancer. I mean, we're talking about probable PCOS here, which is a whole nother topic.
Yeah.
But it's definitely something to get looked into ASAP.
Yeah, definitely. I get that question a lot too about, I only had one period every how often, and I'm like, well, you have to get, because again, it could be your thyroid, it could be something else. There's other things that can cause women not to have normal periods, and don't let that go, even if you're not trying to get pregnant, because it's still good for your overall health to know why you're not getting periods. Okay, let's see. Do patients with endometriosis have a higher rates of ectopics and or miscarriage?
Unfortunately, ectopic is a higher likelihood because of that scar tissue. Yes. Will we always diagnose endometriosis when we diagnose ectopic pregnancy? No. So it doesn't go hand in hand in that way. But yes, likely because of the scar tissue. Miscarriage rates, I personally have never read that.
Yeah, I haven't either. I think if anything, it's that they're not even allowing the egg to meet the sperm.
So you wouldn't even get to that point.
Yeah, it wouldn't even get to that point.
Yeah,
so I think that's the primary role that endometriosis would have with fertility.
Yeah.
Let's see. Is it normal to have pain with ovulation?
It can be, definitely. You can have pain. You can even have bleeding with ovulation. I wouldn't say that's normal. And I would get that checked out though before you can chalk it up to normal symptoms, especially if it's severe and you're requiring like a lot of medications.
Yeah. Let's see. Okay, so those are all the questions we have. I appreciate your time. I don't think we missed anything. I just wanted to do a general overall view. As far as fertility treatments and that for endometriosis, that's outside of our scope, because that goes to other things that the REI might do once they're trying to get you pregnant. Although there are some things that general OBGYN can do. Would you agree that, as far as fertility treatments go, and since we're talking about endometriosis, I think my feeling is that every OBGYN has certain things that they're comfortable with. like we mentioned earlier, as far as doing to help women get pregnant. But then, once that is met, then they would refer them on. Correct?
Definitely. Yeah. I mean, some people will do nothing in regards for fertility and not even do the workup and send you to a fertility
Yeah.
specialist if they suspect fertility. I will definitely do the workup and give a patient a timeline of when we should start and then when we should send you to the fertility specialist if we need to. And I'll also do something called Clomid or letrozole, another medication similarly, if the patient is a good candidate for it, obviously.
Yeah.
So I will do that. It's one type of fertility treatment. But after that, I'm going to leave it up to the specialist.
Yeah. And then one other thing that just came through, we didn't really talk about it a whole lot of surgery to remove endometrial implants to help with fertility or pain or whatever. What generally is the threshold for proceeding to that type of procedure?
So oftentimes it'll be a known previous diagnosis is definitely, and then a really severe pain that's persisted is a reason to go back in and say, okay, is there like a lot of implants that have re-presented and we need to remove those? But if you've never had surgery and we don't know, and we're doing a diagnostic surgery, if you're doing that diagnostic, you see a ton of implants, you're going to try to remove as much as you can. And there's different ways to remove them. And then if you're having infertility issues, probably at that point, you're probably going to be at the infertility specialist and they're going to do an evaluation and remove those implants, but it could be done at any time in that kind of evaluation. But if it's really severe, and you really have a high suspicion for it, then it can help with the pain and it can help with infertility to remove the large implants, but you just don't know if they're going to be there or not.
Yeah.
It's so hard.
Yeah. And there's no right answer as to how many surgeries can be done. It all depends on the individual and what they see when they go in and what your symptoms are. Again, we talked about it earlier. You could have really bad endometriosis and not really have complained of any symptoms, and then have really bad symptoms, but not have, really bad endometriosis. So every woman's different. Every case is different, I think. But the important part to remember is that you have to get, I strongly encourage getting your women's health care every year, being seen to be evaluated. Use a period tracker to document your pain, your length of your cycles, how often you're having your period, the start date, the end date, so that, if this becomes an issue or is an issue, then your doctor, like Dr. Pallister, can look at that and say, hey, then we might suspect endometriosis. And then, the whole fertility thing. I would just want to close by saying, and I think that we agreed at the top, that having a diagnosis of endometriosis does not mean you can't ever get pregnant. And I want to make that clear because it's not true. You may end up needing some help. You may need to see a fertility specialist additionally, eventually, but that doesn't mean it's never going to happen. So any other closing remarks you might have, and I'll let you go.
No, I had fun.
Well, thank you.
Yeah, it was good.
Thanks. Yeah, this will be up on my Instagram TV, Babies After 35, and I'll tag Dr. Pallister as well. And again, you can find her where?
At Kelsey-Sebold in Houston, Texas. Yes. Okay. I forget there's someone in Dublin. It's the coolest city I've ever visited.
Yeah. Kelsey-Sebold in Houston, Texas, and you can find her at Dr. Megan Pallister, ObGyn on Instagram.
Yeah.
All right, guys. Thanks for your time.
Bye. Have a great day.